There are 4 abstracts that I will talk about. The first one is a Phase III study, the LIBRETTO-432, which tested Selpercatinib, a RET inhibitor, for patients with non-small cell lung cancer resected stage 1B to 3A. Selpercatinib was given the same dosage as in a metastatic setting, so 160 milligrams twice a day for up to 3 years. These results were somewhat expected because they're compared with placebo in the adjuvant setting, and we've seen some benefit, huge benefit actually, with other drugs. I'm thinking about Lorlatinib for ALK fusion-positive tumors or osimertinib for EGFR mutant non-small cell lung cancer. So the median EFS, which was the primary endpoint of the study, was not reached, with a median follow-up of 24 months for Selpercatinib. So the median follow-up was actually shorter than the planned duration of Selpercatinib, with a hazard ratio of 0.17. So we'll see whether these curves will tend to reconverge after the duration of the planned duration of the drug after 3 years, as we've seen with osimertinib in the ADAURA trial. So, and we will see if there's room for extending the duration of therapy after 3 years, or maybe indefinitely for this patient. But these results are very important, and I hope I will see this same study for other oncogene-addicted populations, such as HER2, KRAS, ROS1, etc. The other 2 trials testing KRAS G12C inhibitors in patients with KRAS G12C mutant non-small cell lung cancer in the first-line setting. One was the Crescendo 170 trial, which tests divarasib plus pembrolizumab in 2 cohorts, one cohort with PD-L1 positive and one cohort with PD-L1 negative tumors. The results were quite impressive in terms of efficacy, with an objective response rate of 70%, and a median progression-free survival of 19 months. So very impressive. The objective response rate actually was 73% in the PD-L1 positive and 70% in PD-L1 negative, so very similar among the 2. And the PFS of 19 months was in the PD-L1 positive population, where it was not reported for the PD-L1 negative population, but still very, very promising efficacy. The concern here is in terms of safety with this combining the KRAS G12C inhibitor with immunotherapy. We've seen previous trials showing concerning safety profile, and in this trial there were 65% of grade 3 or 4 treatment-related adverse events, mostly diarrhea of any grade in 75% of patients, grade 3 or 4 in 60% of them, and also other gastrointestinal toxicities such as nausea or vomiting. And also we've seen roughly 20% of cases with elevated liver functional test, AST or ALT, increase of grade 3 or 4. So this is mostly the limitation of applying this drug to the general population, but we'll see in larger cohorts if this is confirmed. And then the other trial is testing Alessandro in patients with KRAS G12C mutant non-small cell lung cancer. Alessandro is another specific KRAS G12C inhibitor. And we've seen some good results with combining Alessandro with pembrolizumab or in monotherapy. In monotherapy, the objective response rate was 78%, while combining this drug with pembrolizumab was up to 81%, but the response rate was up to 95% in those with high PD-L1 expression, meaning PD-L1 TPS of at least 50%. Here the toxicity profile, of course, is comparing to different trials indirectly, so it should be taken with caution, but the toxicity profiles looks a little bit better. The rates of grade 3 or greater adverse events were 30% with this combination, and we've seen 6 to 8% of AST or ALT increase of grade 3 or 4. So maybe this combination is a little bit safer, a bit tolerable, but we'll see with larger sample size if that's confirmed. The last but not least trial is the CROWN trial. We've seen the 7-year update of this trial. This is a trial comparing Lorlatinib to crizotinib as first-line treatment for patients with advanced non-small cell lung cancer harboring ALK fusions. This is, I think, the drug that is giving us, in non-small cell lung cancer at least, the best results so far, as the progression-free survival is still not reached after 7 years, with an hazard ratio of 0.19 versus 9 months of median PFS with crizotinib. The risk of having a progression in patients who did not have a progression after 2 years was 79% risk of not having progression, so up to 7 years. So it's very good results and very reassuring for patients with who receive this drug up to 2 years without progression. So incredible results, and yes, this is the best we have so far in non-small cell lung cancer.